Hello and welcome. My name is Barkha Dutt. You're watching the Mojo Story, a platform that has been on the ground relentlessly through the length of the pandemic. Even now, as you can see on a rainy evening, I am sitting literally by the roadside as we continue our travel through the hinterland, through rural India, where we have been tracking, of course, as you know, the undocumented deaths that are taking place, whether it's mass graves, bodies floating in the Ganga, or of course people dying in the villages at their home. But now we have a brand new complication. We've been hearing about the so called black fungus infection for many days, but it is becoming a reality. And like COVID is hitting our small towns and our villages, black fungus is also making its way into our smaller towns and our villages, creating yet another public health challenge on the ground. We are going to be discussing this phenomenon from ground zero with our panel of experts. Let's bring them up now on the screen one by one. Let me introduce on the program Dr. R.K. Mani. Welcome to the program, sir. We're also joined by Dr. Ambrish Mithal. Dr. Amit Thadani is joining us from Mumbai. And Dr. Chhaya Shinde is also joining us. And we'll be joined by Dr. Akshay Nair in a moment from now as well. Now, what is really important is to explain what black fungus is, why it is coupling itself with COVID, and whether indeed the much debated use and misuse of steroids has something to do with it. We'll be talking to our experts in a moment from now. But as I said, we believe in ground reporting. We believe in going to where the story is. And so we traveled 3.5 hours away from the national capital to a town called Karnal, where a 65-year-old woman, Rajvanti, has just died from black fungus, creating panic in the state. And now all 300 patients in the town of Karnal who are being treated in the government college are going to be screened for black fungus. And remember that this is a disease that needs anti-fungal infections that are expensive. So this is the story of Rajvanti, who died from black fungus as told by her son in the city of Karnal. After COVID reaches India's hinterland, sweeping through small towns and villages, a new complication has been the phenomenon of what's being called the black fungus crisis. At the moment, we're in a small neighborhood in Karnal. We're about 3.5 hours from Delhi. And it is here in this neighborhood that we have seen the first death of a 65-year-old woman, Rajvanti, from black fungus. She was in hospital for 12 days for COVID. And then, like in so many other patients who are recovering, in fact, from COVID, she developed the black fungus infection. We're here to talk to her son about exactly what happened and what they went through. जैसे कि हम यहाँ कह रहे थे कि आपकी मम्मी राजवंती जी की डेथ हो गई और हॉस्पिटल के रिकॉर्ड्स में कोविड हुआ, फिर उनको ब्लैक फंगस हुआ, तो क्या हुआ, कितने दिन? हमने सुना 12 दिन तक हॉस्पिटल में थी।
13 दिन हॉस्पिटल में रही थी। मार को उन्होंने बोला इंजेक्शन लगवाओ, हमने टिक्के भी लगवाए हैं, कोई ऐसी वो नहीं हुई है।
आपको इंजेक्शन लगवाने के लिए बोला?
हाँ, हमारे को इंजेक्शन लगवाने के लिए बोला है। फिर आँख वाले डॉक्टर का बोला है, बोले बुला रहे हैं। फिर एक दिन डॉक्टर आया और फ़ोन में अपनी फ़ोटो खींच के लेके गया।
तो मैं अपने दर्शकों को समझाना चाहती हूँ, इन्होंने जो इंजेक्शन का जिक्र किया वो ब्लैक फंगस में एक एंटी फंगल इन्फेक्शन है, उसकी ज़रूरत पड़ती है। और दूसरा इन्होंने आंख की जिक्र की। इन मेनी ऑफ दीज केसेस सर्जन्स आर हैविंग टू रिमूव द आई टू सेव द पेशेंट। अच्छा, उनकी आंख में क्या हुआ?
आँख लीली हो रही थी, बाहर निकल रही थी, मुंह में छाले हुए थे, कुछ नहीं खा रही थी वे।
तो डॉक्टर लोग आपको क्या समझाए कि ये क्या है, कोविड है कि ब्लैक फंगस के नाम से उन्होंने आपको समझाया?
डॉक्टर ने कुछ नहीं बताया हमारे को, है ना, हमारे को सिर्फ ये कागज दिया है, ये चीज़ है, चाहे आप एमएलए की लगवा लो, चाहे किसी मंत्री की लगवा लो, कोई कार्रवाई नहीं करी है।
जो इंजेक्शन उनको दिया उसके पैसे सरकारी अस्पताल में मिले कि आपको देने पड़े?
वो उसके पैसे हमने दिए हैं। 6,500 का टिक्का आया, चंडीगढ़ से मंगवाया हमने। 4400 रुपये का टिक्का, 2100 रुपये का अंतर आया हमारा।
ये एक और प्रॉब्लम है कि अगर आप देखें तो जो ऑर्डिनरी इंडियंस हैं, ये इंजेक्शन काफ़ी एक्सपेंसिव है। इट्स एन एक्सपेंसिव इंजेक्शन, 3500 रुपीज़ फॉर वन इंजेक्शन। ये कहते हैं कि 6000 रुपया आपने स्पेंड किया।
हाँ, 6000 हमने टिक्के के कनाल से लिए हैं। वो टिक्का यहाँ लगवाया, उसके फिर बाद यहाँ कोई टिक्का नहीं मिला। चंडीगढ़ से मंगवाया, 4400 रुपये का टिक्का मिला हमने, वहाँ से 4 टिक्के मंगवाए हैं। बोले डॉक्टर ये आपको 14 टिक्के लगेंगे, 14 टिक्के करा परमानेंट तिंगिरा है मार को, फिर वही बात है नहीं मारे हुए।
So the injections have to be given over a period of time. They're anti-fungal infections. They're given intravenously, and in many cases, as we've been seeing, the eye has had to be removed. आप आंख अपनी मम्मी की आंख के बारे में बता रहे थे, उसके बारे में बताइए क्या हुआ?
आंख वो लिल्ली हो रही थी, उसको बोला इसको चेक करो डॉक्टर जी, लोग अभी बुला रहे हैं, लारे दिन रहे हैं, 10-11 दिन लारे दिए हैं, क्या हुआ है? वो मुँह भी, खाना पीना सब सारा कुछ छोड़ दिया था उनने।
अच्छा एक बात बताओ, आपकी मम्मी को क्या डायबिटीज थी, जिसको कहते हैं शुगर ज्यादा थी?
शुगर बहुत ज़्यादा, शुगर दिखा रहे थे, जितनी बार शुगर चेक करी 450 से कभी 500, एक दिन मार को 250 शुगर दिखाई उनने।
So this is important because one of the vulnerable groups for black fungus is those who have diabetes or are compromised in their immunity in other ways. For example, HIV or cancer. And then if you treat their COVID with steroids, the steroids makes the sugar further shoot up. This is an infection that travels through the sinuses and often to the brain. And as we've been saying, it often leads to the removal of the eye. Sir, आप ये बताइए कि सबसे ज़्यादा प्रॉब्लम मम्मी की ट्रीटमेंट कराने में अस्पताल में क्या हुई?
वो तो ध्यान नहीं है हमारे।
सबसे मुश्किल जैसे आपको क्या हुई? एक तो टिक्का लेने में, इंजेक्शन ढूंढने में।
टिक्का तो लिया जाए था, वो फिर आगे तो उनने वो नहीं कराया, कार्रवाई नहीं करी है। टिक्का रात को एक बार लगाए थे, उसके बाद नहीं टिक्का लगाए थे।
टिक्का यहाँ पे अस्पताल में, सरकारी अस्पताल में नहीं था, आपको लाना पड़ा?
सरकारी हॉस्पिटल में कोई दवाई नहीं है, सारी दवाई बाहर से ली है। सिर्फ में गोली, एक रुपये वाली गोली खिलावे थे, इन्होंने कहा ये गोली खा लो, गोली वे खाए नहीं थे।
अच्छा, पैसे को लेके भी प्रॉब्लम हुई? आप क्या काम करते हैं?
वो पैसे तो दिहाड़ी मजदूरी है, कहाँ से पैसे लाएंगे, कैसे कर लावा पैसा, दिहाड़ी करनी है सारे दिन हैं। टिक्के भी वास्ते पैसे कहीं से इकट्ठे करने पड़ते थे हैं, ये प्रॉब्लम है। यहाँ हमारे हॉस्पिटल में कोई दवाई नहीं है, कोई वो नहीं है, कार्रवाई कुछ नहीं है, हमारी सरकार बेकार है, ये है।
तो लोगों में गुस्सा है कि इंजेक्शंस का बंदोबस्त उनको खुद करना पड़ा। आपने ये नहीं कहा कि सरकारी अस्पताल है, यहाँ इंजेक्शन भी मिलना ही चाहिए?
हमने बोला डॉक्टर को इंजेक्शन यहीं से मिलना चाहिए, बाहर से क्यों ले हुए इंजेक्शन? जी सरकारी ये आप मंत्री को पूछो, MLA को पूछो, आगे ऐसे मंत्रियों की बात सुनावा मार को। डॉक्टर भी हमने कई बार बोला है इंजेक्शन यहाँ से दो, आप टिक्का यहाँ से लगाओ, दवाई है कि नहीं है, ग्लूकोज।
कितना ट्रीटमेंट पे आपने पैसा खर्च किया?
मैंने तो ध्यान नहीं है,
लेकिन इंजेक्शन पे तो जरूर।
हाँ, इंजेक्शन पे और टिक्कों पे बाहर से जो सी दवाई लाया, मैं सारी बाहर से करी है, सिर्फ ग्लूकोज उनने लगाई है और कुछ नहीं लगाया उनने।
तो आप यहाँ देख सकते हैं लोगों में गुस्सा है। ये राजवंती जी का घर है, ये राजवंती जी के यहाँ पर बेटे हैं, और ये एक छोटा सा घर है, एक छोटी सी कॉलोनी है। ये गली नंबर 7 है हंसी रोड की, करनाल की। और मैं आपको इसलिए दिखा रही हूँ क्योंकि अब ये जो कोविड की सिर्फ चैलेंज नहीं है, अब हम एक ब्लैक फंगस फिनोमिनन की बात कर रहे हैं, और यहाँ छोटे छोटे शहरों में अब ये फिनोमिनन हो गया है। इनफैक्ट जो गवर्नमेंट मेडिकल कॉलेज है, वहाँ पे जितने भी कोविड पेशेंट्स हैं, हमें बताया जा रहा है कि जो 300 कोविड पेशेंट्स हैं, अब सभी की स्क्रीनिंग की जाएगी, ब्लैक फंगस के लिए टेस्ट किए जाएंगे। एंड इनफैक्ट इट हैज़ बीन डिक्लेयर्ड अ नोटिफाइड डिजीज हियर इन हरियाणा। बट इमेजिन वी आर जस्ट इन अ स्मॉल लिटिल कस्बा in Karnal, and you're seeing the anger of one son who has lost his mother, who had to mobilize money, who had to mobilize those anti-fungal infections injections and get them from outside, and somehow find the money and the resources to pay for them, expensive anti-fungal injections, so to say. And you can sense his anger, but also his confusion, because nobody really understands what this is, and now it is compounding the COVID crisis even in small towns and small gullies like this one. The story of Rajwanti, the first recorded death from black fungus in Karnal. All right, so just when we did not need any more complications, we have these are lower income neighborhoods. These are families that can't afford infections that are needed in the treatment of black fungus, and this is now causing a great amount of anxiety and a great amount of resumed debate over the use of steroids for the treatment of COVID. We go straight to our panel. Dr. Mithal, what do we know so far? Of course, we know that this is an infection that predated COVID. It was, in the air, so to speak, but it was a rare infection. We're now seeing an increasing number of these cases coupled with COVID, even in people recovering from COVID, and people are choosing to link it back to the use of steroids. Is that where you see the fault line? Is it that the steroid use is somehow triggering the black fungus reaction?
Yes, Barkha, this is very unfortunate. This is the last thing we needed, as somewhat the numbers, at least in the cities, slightly declining. The last thing you needed was a sort of epidemic of this type. And quite clearly, this is a fungus that is normally present, as you said, in the air, often in our nose also, in the nasal mucosa also. So it's like a seed that's lying there looking for a fertile soil to grow. And a fertile soil to grow so far in our practice was people who had very severe diabetes, especially insulin-dependent diabetes of children, where they also got some acidosis, and that's what linked to the growth of the black fungus. And we used to see 1 or 2 cases a year, even near maybe 3 cases over more than 3 decades. What is happening now is unprecedented because a combination of severe hyperglycemia, very high blood sugars, linked either to the diabetes itself, aggravated by the COVID infection. And as we know, there are some studies that the coronavirus may be directly aggravating diabetes. Plus the fact that steroids are the only life-saving drug, so to speak, in this condition. And a use of steroids judiciously or injudiciously, especially the latter, and also the fact that diabetes may be neglected in many of these patients has led to a combination where you have high blood glucose, you have possibly some acidosis, and you have suppression of immunity both by the virus and by the steroids. So that's a heady cocktail for the fungus to grow. And I don't know if it's anything to do with the weather. With the humidity increasing, all those factors could also be playing a role because the numbers are just humongous. I mean, we could never imagine. And in Delhi, we are following Bombay exactly by a few weeks, And the same thing happened when my Bombay colleague said that we are seeing black fungus. I said it must be because of humidity there. And, we haven't seen anything here. And I had to eat my words the very next week. And, we are now seeing an exponential increase in these cases across the NCR. So it's pretty scary because the outcome of these patients has never been good. It's not that the outcome has been affected by what is happening now. These patients of mucormycosis, regardless of the cause, have never had good outcomes. So it is definitely a big challenge for us to face now.
So, as you said, that the mucormycosis has existed before COVID. What is triggering it now is seen to be the steroids. Does this make you review your use of steroids, Dr. Mithal, in COVID treatment?
No, the use of steroids in COVID patients is very clearly defined, actually. There are some gray areas, but some are very clearly defined. That is a drop in oxygen, for example, in all trials has been shown to be an indication to use steroids. Some people use, since with increasing use of CT scans of the chest, and Dr. Mani will enlighten us more on that, some people use it when they see the CT scans showing extensive disease or marked deterioration in the condition, usually in the second week, at least after 5 or 6 days. The first 5-6 days, there should be no use of steroids normally because that's the stage when the virus is proliferating and you need the body's inner immunity to fight the infection. And steroids suppress that. Steroids are useful in the second half of the disease when there's an inflammatory reaction, the oft-used term cytokine storm and all that. And that's the only thing that works. None of the other cocktails that are being used actually do anything. So judicious use and correct dose and correct duration is also important, because I do think that in some cases, steroids are being used for very long, and also think that astronomical doses are being used sometimes, of course, left to the clinician's judgment, but based on the data that we see, they do seem excessive.
Now, I want to go to Dr. Mani. And Dr. Mani, the case that we were, actually profiling here in Karnal of the 65-year-old woman who died, she spent 12 days in hospital. The first 10 days, she was only being treated for COVID, and it was only in the last few days that she developed this black fungus. And we're actually seeing black fungus in recovering COVID patients, right? Now, you know, I don't know what doctors should do given this added complication. And Dr. Chhaya and Dr. Thadani will tell us we're seeing horrific stories where surgeons are having to remove an eye, often remove someone's eye to save their life. In Rajwanti's case, she just died. Dr. Mani, what's your take?
The
Can we
case
unmute
of
Dr. Mani?
Rajwanti in
Yes.
Karnal that brings out many things. It illustrates the way this black fungus comes up, and it also brings out the pathos and the tragedy affecting the family. Firstly the mortality, then in the run up to the mortality, there's so much of expense and anguish. Now, what happens is we have seen Mucor on a background of immunosuppression before, in the context of chemotherapy or in the context of bone marrow suppression due to any reason. But this degree, this volume, is giving us a message, and we must heed the message. I'm not going to run away. I'm going to call a spade a spade. It is because we are overusing, we are misusing steroids. Simple. It's not just the steroid. There's a whole cocktail of medicines we give for fear of losing the patient or under the mistaken belief that this is okay, right? It is not okay. It is off-label use. What we do is we use much heavier doses, much earlier, and not being very rigorous about the timing and the indication, and much longer durations. We seem to also use it along with prophylactic antibiotics, so-called prophylactic or empiric antibiotics, those which have not yet been proven to be necessary, but we think it might get, so preemptively we use them. I must add one more thing, which has not been spoken about. We preemptively add antifungals as well. We add anti-candida, anti-aspergillus. Now, what happens is when you preemptively do something, it doesn't stop anything except it stops, maybe stopping a few, but allows the emergence or aggravates the emergence of more lethal bugs. That has happened with bacteria, that's now happening with fungi. When we use anti-aspergillus medicine, when it is not proven or it's going on, you will get emergence of mucor. That's why you're getting it after discharge. Everything looks hunky-dory, and you are not navigating the sugars, as Ambrish said. That patient said it reached 500, it reached 450. It was usually in 400s, 500s, and the lowest it went was 250. Ambrish must have listened and cringed. So this is the sort, because we are short of staff, we are short of perhaps expertise, because everybody is spread thin. So the usual rigor of managing sugars, keeping them under 200, is lost, either within the hospital in the ICU, or in the run up to the hospital, because many are treated at home with steroids preemptively, and post discharge. This cannot be duplicated at home, the rigor with diabetic control. So the cautionary tale, we must wake up. It's an eye opener, and this can be prevented. We
So
must
hang on,
have the usual rigor.
I want to jump in. You are very clear that you believe this is being triggered by the ill use or the misuse of steroids in COVID treatment. You're very
Yeah,
clear about that.
I'm very clear, because you see, the proof of the pudding is in the eating. We are producing them. All right, they are not accompanying COVID in other countries. Okay,
That's a
and we have
very good
seen them
point.
being produced, and we have
Yeah,
seen them being produced before with other illnesses. I
yeah,
have seen we producing aspergillus by a lot of this cocktail of steroids and antibiotics. Now it's gone one step higher, and it is known that we get disseminated mucor in the ICU setting when we use a lot of very immunosuppressive medication. I must throw
So
into this the
Yeah.
tocilizumab as well. What I'm saying is everything that we are doing is immunosuppressive in the belief that we must suppress this immune response.
Well,
So we are
I
doing it in a sledgehammer fashion.
Well, I just want to tell you, some of you know this, that when I had COVID, I was given steroids, even though my oxygen did not fall at all. And it took me, I tapered off. My last day of steroids was yesterday, and I've had all kinds of reactions, including swellings and weakness and all kinds of other weird things. So I'm actually really scared to hear some of this. But the very good point that you make is this is not accompanying COVID anywhere else. Before I go to Dr. Amit Thadani, Amrish, I know you wanted a brief interjection there. Go ahead.
At that
Amrish?
point.
Yeah.
Yeah, sorry, he's already said that it's only in India. This morning again, I researched everywhere. It's only being reported from here. There's something we have been wrong, right? Obviously. I mean, even if there's environment, climate, this, that, there is something else in our treatment strategy that is different because no cases have been reported from anywhere else.
Yeah.
Anywhere
Uh,
else in the world.
So one of the things we are doing differently is because our hospital systems are so stretched, doctors are very focused on keeping people out of hospital. And what is happening, Dr. Amit Thadani, is that steroids are being given in week one. I think it happened with me, so I'm a case study. And I know this is happening with a lot of friends. Is that what we are doing wrong? Is that what we are doing different, Amit?
Right. Now, I don't think so. We have seen it in patients who haven't had severe disease and who haven't received prolonged doses of steroids also. And one such case we have seen. I believe that it's just more than just the steroid use. We've been using steroids since decades, and prolonged use of steroids has happened, in many immunocompromised conditions as well. So it's not just the steroids. Obviously, there is something else that's also triggering it. I believe that it may be provision of an excessively moist environment and excessive amount of steaming that is triggering it, because mucor grows in moist environment. It just loves moist environment, and it loves a host who will be immunocompromised. So a combination of excessive humidity with uh, in an immunocompromised patient is probably causing this to trigger more, rather than just the fact that the patient is on steroids alone. So I believe
So
that
you
there's
don't,
something more.
you're not convinced. You're not convinced that it's the way we're medicating COVID. You believe it's something in the Indian mahal, but that has been there earlier also, Amit. The point is that that didn't have to come COVID. Why is it accompanying COVID? That's what we must ask ourselves, right?
Definitely, COVID itself is also triggering. It may be environmental, or it may be just the strain that we have, because we didn't see much of mucor in the first wave as such. I believe we saw just one case at our hospital, but in this wave there are definitely many more. So there is definitely something environmental also, which is there. It's not just the use of steroids; otherwise, it would have been across the board, seen in all countries. One thing that immediately came to my mind was steaming, because we had one such patient who was constantly steaming and did not have severe disease, did not receive prolonged steroids or prolonged immunosuppression, and yet developed a mild degree of mucor which required treatment. So there is probably something more than just the use of steroids which is at play over here.
Okay, something to think about. Dr. Chhaya Shinde from Sion Hospital. How many surgeries have you had to do to tackle this, and how often have you actually had to lose a patient's eye to save their life?
Yes. Almost daily one surgery we are doing for mucormycosis, where the infection has reached the sinuses, then from there it has gone to the orbit, and it has gone so much extent that the patient has swelling, then he cannot move the eyes, then the vision drops, then the eyelid droops, and the pupil also does not react, pupil is also affected, and vision has already gone, swelling is so much. We examine the patient on radiologically also and clinically also. We do take the history, and then we see that the infection is now reaching the brain. So much before that, we try to, because life is important, eye is important. ENT department helps us. They do the debridement, they check the nose, they check the sinuses, they do the scopy, and then we have to prevent the for life and eye also we have to prevent. But unfortunately, most of the patients, when they reach to us, when they come to us, already it has gone to the orbit, and from there it is almost entering the brain. So before that, then we have to remove the eyes. It is destructive surgery, and very very sad that we have to remove the eyes. We are here to salvage the eyes, the patient's vision, but it's very destructive surgery and very difficult situation that almost daily one. Now at present today, I have almost 6 7 patients. Um, Half of them we are operated, remove the eye, and some are on the verge of going to the operation theater to remove the eyeball. Some are waiting for getting the radiological investigations done. And we have lost some patients also, young patients. Now, one more thing I want to say that previously, like patients with senior citizens, and then the immunity is less and they cannot fight any infection. But now we are seeing the new thing that 41 years patient, we lost the patient. The 38-year patient is coming. Patients are coming to us from remote places, villages. They are coming to Mumbai, reaching, taking some vehicle, reaching here. And when we examine, mostly they have lost the vision, the eye swollen, the orbital, the contents there is infection, and then we have to go and take out the eyeball. There is no other way to have the patient's life. That is the thing.
What I'm really horrified to hear is you're saying you're performing one such surgery every day where you're removing somebody's eye
Yes,
because of
yes,
black fungus. One every
yes.
day.
Yes, yes,
And,
almost
and
one. We and ENT department, or oculoplastic surgeon, almost every day or alternate day, it is there that or the patient is waiting, getting fitness for anesthesia. Almost daily one or alternate day one is there only. At present today, we have almost 7 patients in the hospital, 6 7 patients.
and this is one hospital only, one eye
This is one
surgery every day.
hospital. Yes, of
Uh,
course, ours is a medical college. Yeah,
yes, ma'am.
ours is
Ma'am, are they mostly have recovered from COVID, or are they in the middle of COVID when they
Madam,
come to you?
mostly they have recovered. They have recovered from COVID. They are post-COVID. Now, some patients they do not have COVID report with them, or they're negative. Some patients they are positive. There some are still positive. Some have become negative, and then in 1 or 2 weeks they see this that the eye is getting affected, swelling is there, and maybe initially, madam, the post-COVID also patient is so weak, and to get the stamina and become completely normal, it takes time after getting the COVID infection. So in that, maybe the patients are not realizing eye swelling is there or vision is slowly dropping. One more thing, when one eye is affected, the other eye is functioning, and hence the patient may not be able to say that the vision is less in one eye. When the patient goes to have bath or wash the face, and one the hand or palm closes one side, and they realize that they are not able to see. So that is the time they must be telling the relatives. Then the relatives have to get money or to get the patient to good doctor and all that. And generally also the patient is debilitated, weakness is there, already emotional trauma is there. Whenever COVID is there, one more thing, madam, when one patient gets, nowadays we are seeing whole families are affected in the second wave, not only one. So and to get help in this situation is difficult. If somebody is there, previously when COVID was not there, if somebody is sick, then somebody will come and help you. Friends are there, relatives are there, your servants are there. Now in this situation, second wave, people are afraid to help, to enter their home. So all these social factors are also there, and by the time they must be realizing that something very serious is happening to the eye, it also is delayed.
Very disturbing details you're sharing, and I'm staggered by the numbers. Would you say that you have seen this in the last few weeks? Is there a
Yes, yes, yes.
time frame where
Last
you're
few
seeing a
weeks,
sudden last few weeks?
last these 2 3 weeks, daily at least one we are seeing. These 2 3 weeks, it is increasing, and the age is also going down. Younger and younger patients, like 41, 38 years, like that.
Right.
Young patients also.
So I
We
can
do
I
get
can
above 60, 70 years, but young also, man.
Right. I can see Dr. Akshay Nair also joining us. Hi, Akshay. Dr. Chhaya Shinde of Sion Hospital was just telling us that she's been performing one surgery a day to remove an eye for the last few days. She's currently has 7 patients, but literally one surgery a day, and all of them are post-COVID. And I'm actually in Karnal, where I just reported the death of a 65-year-old woman from black fungus. So this has started hitting our smaller towns where families can't afford the antifungal infections. Can I quickly get your take? What are you seeing? How many such surgeries are you performing? How often are you having to remove the eye? And where do you weigh in on whether this is to do with steroids or whether this is to do with something else?
Yeah, I think in the sense of the number of cases, I think a day, one surgery a day is probably a fair assessment. That's pretty much what I am doing as well. And the thing that is adding to the woes here is the lack of availability of antifungal drugs. Amphotericin B that is not available is really making things difficult, because in the treatment of COVID, it's three things. It's taking in the treatment of mucormycosis. Sorry, it's three things. First is the immediate ENT surgery that is needed to drain out the sinuses, to debride the sinuses, as it were, and any eye surgery that may be needed to remove the eye, a long-term antifungal medication, as well as controlling the diabetic status of the patient. Any one of these three doesn't fall in place, the treatment is doomed. It would not succeed. You would have the fungus come back in some way or the other. And remember, these are people who have been bruised and battered by COVID, and just when they think they have come out of one calamity, something like mucormycosis gets hold of them, and if the health and financial woes weren't it, you have hapless relatives running around from pillar to post for this medicine. So it sometimes you don't know. And just to add one thing, I have had a patient whose family is seriously considering not going ahead with surgery and taking him home. He's a 77-year-old gentleman who's had 2 surgeries already for mucormycosis, and his diabetes doesn't seem to get under control in spite of maximal therapy, and the mucormycosis is resistant to treatment. In spite of doing as much as we can, he's not improving. The son and the family are actually thinking of that, because they have their lives to go on with. On one hand, they still are trying to keep him in hospital and run around to get the medications, have their daily routines, going to jobs to earn money. So things are becoming difficult. To answer the point about whether it is steroids, whether it's diabetes or what, one thing. So in the past 3 weeks, we have seen about a handful of cases, close to 7 patients who've been non-diabetics before COVID. They probably had a blood test done or an annual checkup done in the last year. So they actually have reports with them that show that they were not diabetics before COVID. And post-COVID, they're now being tested, and newly onset diabetics. People who've never been diabetics are now turning diabetics post-COVID. And they're not aware of this. During the course of, say the 2-3 weeks after recovery from COVID, their blood sugars are sustaining at very high levels. And by the time they realize that, there's something wrong, the blood sugar is high, the mucormycosis is the first presenting sign of diabetes to the doctor. So they are as surprised as the doctor when they learn that they have diabetes. But we also have a small subset of patients who've home isolated. So there's no steroids in them. There is no oxygen in them. They've just recovered from COVID at home, and they've come to us with mucormycosis. So although they were diabetics, it's got something.
Without any steroid treatment at home.
Yes, without any steroid treatment at home, without any oxygen. So the theories of the humidifier, the oxygen in the piping, all of that would go out of the window when we have patients like these. Diabetic patients who've recovered from COVID at home with no steroids. So steroids is just adding fuel to the fire. The fire itself is COVID and diabetes together.
Okay, so Amit, I think that speaks to the point that I think you were trying to make, that there is an element of the misuse of steroids, but it doesn't tell the whole story. So before I go back to Ambrish and RK Money on this, very disturbing from Akshay and Chhaya on the number of eye surgeries that they're performing to try and save lives. Amit.
Yes, it is very disturbing, and the key is to pick it up very early, which is again very difficult. It's in either intraoral, intranasal lesions which are not clearly visible, Generally, you would come to know only once the disease has advanced. The signs are very subtle, so it's very difficult to pick it up early. If by chance, we screen patients and pick them up relatively early, then maybe, we need not remove the eyeball. An endoscopic surgery such as a FES can take care of the disease itself. But as of now, it is very morbid. The survival rates are also not great, maybe not even 50%, I think. Though now, since we're getting so much of experience in it, I guess more patients should be saved with more radical surgeries. So in fact, right now at the hospital I'm in right now, we have two patients currently admitted with mucor, and both are doing pretty well. But yes, they are morbid, they are diabetic, and it's going to take a very long time.
So the fault line in this debate really remains how much we think it's to do with the misuse of steroids. And Akshay and Amit are not fully convinced that the steroids tell the whole story. But Dr. Mani and Dr. Mithal are asking the all-important question: why is this happening only in India? Dr. Mani, let me take this back to you. Firstly, like really disturbing. This is obviously much bigger than we thought it was. If our eye surgeons are performing this number of surgeries.
I think, Barkha, I mean, I accept the points made by my colleagues. There may be other factors, all right. But it always happens that an entity has several factors impacting it. But by far, the predominant factors are diabetes and steroids. And India is a country of a diabetic epidemic as well. Okay, either detected or undetected. And many people may surface as diabetics in these circumstances of a serious infection, a cytokine storm, and then steroids. It is well documented and well known for decades that these two are the predominant factors, right? It is diabetes and immunosuppression. But to see them in such large numbers, we cannot take the alibi of other factors. We must see what we can control. Two things we can control. We can navigate the steroid therapy better. There's always room for improvement. I think we are using a lot of dosing off label. If we are recommended 0.5 to 1 milligram, we start with 2 milligram. If we are told that 2 milligram is the upper limit, we use 3, 4 milligram, and we even use pulse steroids. Now, pulse steroids have one little paper in a very small study, that's all. But we have large database on recovery trial which says use the small ones. And in recovery trial, it was used in people on ventilators. Now we are using big doses, even people who are not on ventilators. Together with this, we are using a lot of antibiotics. See, our country needed antibiotic stewardship, and we never had it properly. Now the country needs steroid stewardship. We also used many other immune modifying or immune suppressing agents. Empirically, we use a lot of things, right? I mean, which are unproven. Now we are using IVIG and all that. What impact it has, I do not know. We haven't worked it out. We haven't got a data-based analysis. Okay, it's all anecdotal analysis at the moment. This patient had diabetes, this patient did not have. Out of 100 patients, how many had diabetes? What was the degree of control? What were the dosages and duration given? All that we have not worked out. We tend to diagnose ILD accompanying following up with COVID pneumonia, and we use very prolonged courses of steroids. But ILD following up with COVID is a very small proportion of cases. To cover for 5% of cases, we cover everybody with the same dose. So there is time for introspection. As an intensivist, I'm doing intense introspection, okay, where we might be more judicious, more minimalistic. We must have a more minimalistic approach to these immunosuppressants, and we must be very thoughtful. This is very clear to me. Whether there are environmental factors, it's not clear to me. Whether humidifiers do it or not, maybe it's correct. Maybe there are something in the fomites, but these, in the published literature so far, these are not the predominant factors.
Ambrish, do you think we're hiding behind or clutching at straws when we try and look for meat, saying it's in the environment? Do you agree with Amit that it's from too much steaming? What do you make of Akshay saying that there have also been some cases where there have been no steroids?
So I think, Barkha, there's always in these things a multiplicity of factors. It's hard to ascribe everything to one factor, but obviously they've all come together in India's case, really. And certainly diabetes and steroids are dominant, but quite clearly, as I said, the humidity in the environment, and I'm petrified of the humidity now increasing in Delhi, for example, and I wonder what's going to do to the fungus here. So, in addition to the other things like fomites, and of course the possibility, which is completely unproven, and just throwing it up in the air, is whether COVID directly, the virus directly, is doing something to increase the risk of mucor. We don't know that. No one knows that. Now, there are 2 points I'd like to make here. One is about eye surgery, and when we teach or taught mucormycosis, if the patient has to reach the eye doctor, we've already lost half the battle, which means it should really be addressed at the ENT level. And if we are reaching the eye, it's very difficult to save the eye. Then you're trying to save the life by saving the eye. But if you are able to address it at the ENT level, the nose level, then you can save the eye probably. So we'll have to be much more proactive in screening these patients, those who've been in a high risk category. When we get data, who are the patients other than the obvious factors, maybe they need a nasal endoscopy much earlier than what we are doing right now. All those things will have to be looked at. You can't wait for the black color and those things to appear to really make a diagnosis of mucormycosis. So something will have to be done proactively there. The second point, what RK was making about diabetes. So I'll not go into details, but we studied 400 consecutive hospitalized patients last year, which we published earlier this year. And out of that, 38% had pre-existing diabetes, known diabetes, right? Another 9% didn't know they had diabetes, but when they came in, their sugars are very high and the HbA1c was high. So they had pre-existing diabetes they were not aware of. And another 7-8% didn't have anything, but they still got diabetes there, or at least high blood glucose over there. So there is a whole spectrum, as my colleagues were mentioning. And so you may not be a diabetic, but the stress induced by the infection, coupled with the steroid, really flares up the sugars.
Would you change? Is it time for us to start changing how we're using steroids, right? So on paper, you're all saying it's when oxygen falls, it's when the disease becomes moderate to severe. In actuality, each one of us who's had COVID has been given dexamethasone in week 1 in sheer panic. I mean, I can name you hundreds of people who have been popping dexamethasone. Is this something that needs to change urgently, Ambrish? And then I'll take it back to the eye surgeons. Yeah.
So I think all the guidelines, Barkha, are saying the right things.
But that's not what we're doing. That's not what's happening. That's not what's happening.
It is. I think I can see some change. The numerous CMEs, the numerous programs that are being done, the numerous experiences being shared from Indians living abroad, or Indians in bigger, or Indian doctors in bigger centers, is probably beginning to get home. And I'm hoping, and I think I can see some change, but I'm hoping that this will be much more stark and clear. And along with steroids, of course, we're talking of steroids right now in mucor, the use of a list of drugs that people get when they're diagnosed with COVID fills a page. And we don't know what any of those things do. For example, in our own study, again, published in Nature Scientific Reviews, Scientific Reports, a couple of months ago, showed that giving high doses of vitamin D made no difference. And everyone's pumping vitamin D. So what I'm saying is that, we have to go by data. We have to go by the evidence, and we have to just keep drilling, keep talking, keep explaining. And that can only come from medical personnel. I'm afraid many of the guidelines are signed by bureaucrats and implemented by bureaucrats. I'm so sorry to say, no doctor will follow that, and they haven't done it ever. So in some areas now, to get a drug, you have to go through some bureaucrat, So all those things are peculiar to India, but the truth is that practice should change, and I think it is changing.
So I want to go back to Akshay and Chhaya on what are some of the patterns that you're seeing that are common across the patients you're getting right now, where you're having to perform these eye surgeries. Is there something, are they all diabetic mostly? Is there something in the nature of their COVID? Is there something about the day that they come to you? How many days have they typically recovered before this happens? Akshay, I'll start with you.
Yeah, so we have now looked at our data and analyzed it pretty well. Most of the patients are those fitting in the moderate or severe category of COVID. Very few who've had mild disease land up with mucormycosis. That's not to say there are none. There are a few. Less than 10% of them are in mild disease. The other thing is that uh, there is a smattering, and I think that's is pointing to what was said earlier about a lack of homogeneity in treatment. An entire page is being prescribed because there are some who've got a drug like called ivermectin, some who've got remdesivir, some have got IV steroids, some have got oral steroids, some have got hydroxychloroquine, and antibiotics has been given to everybody. So we don't know, like to say what was said earlier, it's multifactorial. uh, in the nose, apart from just things like mucormycosis, there are commensals, there are helpful bacteria, helpful fungi, which have a job to perform by staying on the surfaces of the nose. And when we bombard patients with drugs that can kill the entire flora, there are some organisms which are not affected, which then take advantage of that. And to give you an example, there is again a spectrum of antifungal drugs, and there's one particularly very commonly available drug called voriconazole. It's a drug that has select indications. It's useful in other fungal diseases called aspergillosis, not for mucormycosis. On the contrary, if it is given in patients with mucormycosis, it kills off the other fungi and other organisms, which makes the ground, the nasal mucosa, fertile for mucormycosis to go and become invasive. So in an attempt or a half-baked attempt to try to treat mucormycosis because amphotericin B is in short supply or the patient cannot afford, you are ending up worsening the situation by prescribing things. So there is lack of clear guidelines, and that would come from data. Now we're talking about India being the highest number of COVID cases, yet the least number of COVID publications that have stood the the scrutiny of peer review are coming from India. In fact, I want to go back to one paper that came out in Nature that spoke about that actually came out in April, but had looked at 75 consecutive patients of COVID who were admitted at the Veterans Affairs Hospital in the US. And at 6 months following their recovery, what were the changes in all of them? And they said that in the 75,000 patients, they saw 4 patients per 1,000 COVID recovery patients having new onset diabetes, 5 per 1,000 requiring more insulin, 8 per 1,000 requiring more oral anti-diabetic medications. So these are small numbers: 4 per 1,000, 5 per 1,000, 8 per 1,000. But in a country like India, when you're clocking 4 lakh cases a day, that 4 per 1,000 becomes 400 patients. Imagine churning out 400 diabetic patients every day for a month. You have an ocean of patients who know they're diabetics. So coming to answer I'm sorry, I got a little sidetrack about the pattern that we are seeing. A lot of them are moderate or severe COVID patients. One thing that is standing out: none, and I say none with special emphasis, none of them were vaccinated against COVID. All of them are between 12 to 45, with the average being 15th day. The 15th day is from the diagnosis of COVID, not from the onset of their symptoms. The day from when they're diagnosed with COVID with RT-PCR, the 15th day is when they come up with symptoms of mucormycosis. Compared to what mucormycosis used to be seen earlier, when in pre-COVID era, the proportion of patients with eye involvement is very high. The hospital where I also visit, where Dr. Chhaya Shinde is there, our ENT colleagues tell us that this time the involvement of the eye is almost in 90% of the patients. The patients who have only the nose and the sinuses involved is a fraction. So this just suggests that this time around, either
Something has changed.
it's go more aggressive, or we are seeing patients later.
And And your average surgeries are also what, one a day? You're removing an
One a
eye?
day. There have been days where we've done. So I think at about a couple of weeks we were doing up to 3 cases a day, but now it's about one
Wow.
case a day.
Wow. Chaya, if you want to add to the common patterns you're seeing, and then we'll take last comments. Chaya? Yeah.
Yes, I and Akshay, we work together uh, in the number of surgeries also. Akshay is also the plastic surgeon, and I agree with Akshay. Many patients, they are not, mostly they are not vaccinated. By the time they are diagnosed with COVID, and after that they know that they are having diabetes, and then the eye is affected. It is late. That delay is there. Then regarding whether they were diabetic previously, no. Some patients, most of them, 50% I would say, they are diagnosed now with a diabetes. So they were not having diabetes before. So there is some change. And there is this change also, that previously in last wave also we did not see so many eyes affected. So now we are seeing eyes affected. So is there a change made in the mucosa or in the body of the patient by this COVID virus? Is the mutation causing some change, that the virus is gaining easier entry to the nasal mucosa and to the sinuses and then to the orbit? So we need to find out these answers also. We have to prevent, and proactively we have to tell the patient's relatives that you look out for these signs or symptoms. If anything, nose, you get stuffiness, blockage of the nose, then you need to report to the ENT doctor. So we will catch it earlier before it reaches the eye. I agree with Akshay in most of the points.
So before it reaches the eye, it's very important to catch it when it's in the sinuses, because by the time it reaches the eye, it's already too late. Now, I know that people will want to understand in a very basic way what are the signs that they should be looking for. And I think for doctors, I was listening to Akshay talking about all these medicines. I mean, I'm a living case study of this. I had doxycycline for no reason. I had steroids for no reason. I had ivermectin for no reason. I was interviewing, Dr. Swaminathan of the World Health Organization, and she says the amount of pushback she gets from India when she tries to say, do not take ivermectin, do not take plasma therapy, do not take azithromycin, do not take doxycycline, but nobody listens. And we are in a panic situation where we've been over medicating. Doctors are panicked, patients are panicked, and this is the situation we're now in. Let's start with last comments. Amit, I'll start with you. What are the lessons? What should we be doing and not doing?
Yeah, so we need to, of course, pay a little more attention to respiratory symptoms, because mucor is not going to present with cough. Primarily, all your COVID patients will present with cough. So, if any patient developing stuffiness of the nose is to be taken as an unusual symptom. Probably there is some role of empirically planning, an endoscopic sinus, just a diagnostic sinoscopy in patients who are diabetic, to make sure that the nasal passages are not affected with early mucor. That probably should be considered. And of course, the rigorous control of diabetes, and limit the use of immunosuppressants, including tocilizumab as well as steroids. And there are some alternatives now, very interesting ones, which are being researched, which probably we need more data on. So that will also need to be considered.
Chaya, any advice to people who are wondering whether they have this or they don't?
Keep a watch on themselves. Stuffy nose, blockage of nose, numbness on cheek, one side of the face, numbness, swelling of the eyes, that will be later. But the symptoms related to the nose, that they should keep a watch.
I
Mostly
mean,
it will
Akshay,
start on one side of
yeah.
the nose. Yeah.
Akshay, some of us have blocked noses and blocked sinuses at all times. How do we not send people into panic over that?
Yeah, so we need to understand. I mean, not everybody is at risk. If you've recovered from COVID, if you are a diabetic, uh, these are the people whom we are going to be. We are especially vulnerable. So, if you've recovered from COVID and have had a course of steroids, whether it was intravenous or oral, if you've recovered from COVID and are diabetic, or now have found your blood sugar to be a little high, you are then fall in that small subset who needs to be extra conscious and aware. There's no point in alarming people and pushing them into panic, but I think there's a lot of merit in what Dr. Amit said. Maybe it's time that at discharge from a COVID hospital, you tell your patient that if possible, just go and meet your ENT and have a scopy. If not everyone, at least those who are diabetics or who've had now recent onset derangement in blood sugar level. Identify the vulnerable ones is the most susceptible ones is what we need to do, and not push everybody into panic.
Dr. Mani, I'll let Ambrish wrap this up for us, but I want to take you back to your calling a spade a spade. The number of medicines that we're administering, we no longer know what it's doing to our immunity and our fighting capacity.
You see, I must sum up by saying it's an opportunistic infection, mucor. It's not an infection just because the spores are ubiquitous, or it's from human to human contact, or we get it from the linen. It's an opportunistic fungus. You set the scene. We are doing it. We are unwarily walking into the trap. What is happening is we are using the drugs, right drugs perhaps, but not in the right dose and for the right duration. We have to learn to be a bit more conservative in the use of these, and we must weigh the evidence. We are not to use poorly evidenced drugs, because there's so many others into the fray. I don't want to name them. I don't want to promote even by naming the number of immune modifiers in the market now. As Ambrish said, there's a whole page of them. It's not just ivermectin. These are little benign. There are more strongly immunosuppressive medication. Please, this is a signal for us to stop using them. Use what is evidence-based. You may stray a little bit, but not so much.
I think that's well said, Ambrish. That the black fungus is telling us something about how we've been handling COVID, and we need to learn from it.
Yes, I think to wrap it up, as you said, basically the strategies would be greater awareness amongst the public, so that we need to make people aware of the strategy if they feel any particular symptom as has been described. I think early endoscopies, and we made a plan definitely for those who've received high doses of steroids and have had very high blood glucose to get one screening endoscopy, nasal endoscopy, before they leave the hospital. So I think that kind of proactive measures might actually help us in the long run. Good diabetic control, sometimes saving life at that point becomes very important, oxygen, etc. And diabetes gets neglected in the bargain. That cannot be the case here. Quite clearly, even for COVID outcomes, diabetes control is important. Judicious use of medication, and already emphasized enough, but also the fact that I'm fearing that next year azithromycin and doxycycline will probably be all resistant. I mean, we won't have anyone. These drugs won't work anymore in Indians. That's my guess. And lastly, I think I do see it, despite all that we are saying, as a great opportunity to study this, because no one has the opportunity to study mucor like this. I mean, it's not a great way to get an opportunity. But the fact is that we might learn something which may help us in the future, because who knows how many pandemics, how many waves, whatever. So if we keep our data carefully, which is not a strong point with Indians, we can actually get information that will help us a lot in treating patients. Those are my points.
Okay, we leave it there. This is a frightening phenomenon. The fact of the matter is, it's already problematic that COVID is hitting small towns, villages, and now we have a situation where you're even seeing black fungus come into small towns like Karnal, where I am. Just before we close, Akshay, I just wanted one quick word from you. The family that I met today was complaining bitterly about the cost of the anti-fungal injections that have to be given in this treatment. Could you just tell us a little bit about this injection and how much of a serious shortage you're facing?
Right. So the drug that is being used to treat mucormycosis is amphotericin B. The amphotericin B, the drug itself, is available in two forms. One is the standard lyophilized, which is technically the molecule is called amphotericin B deoxycholate. And then the other is liposomal amphotericin B. The liposomal amphotericin B is safer, has lesser side effects on the kidney, fewer drug interactions, and a better efficiency. So everybody prefers the liposomal molecule. But in a day, a patient would require up to 5, 6, 7, or 10, depending on their body weight, of these liposomal vials or 10 ampules of the liposomal molecule. Each vial costs anywhere between 3,000 to 7,000, depending on the brand or the company that is selling it. So that's about 30, close to, say, the 5,000 rupee vial. That's pushing them anywhere between 35 to 50,000 rupees on the drug alone. Now imagine having to take this for up to 3 to 6 weeks, depending on the severity of the disease, in the first, the first part of the treatment. After this, we switch them over to another syrup, which is another drug which is available as a syrup called posaconazole, which itself is 20,000 a bottle. So these are expensive drugs. In our public hospitals like Sion Hospital, where Dr. Chhaya and I are there, we do, our patients cannot even afford liposomal, so we are sticking to the older molecule, which is 350 rupees a vial, which is supplied to us through the municipal corporation. There are side effects. These are diabetic patients who often have kidney issues, so that limits the amount of drug we are giving it. So it's the physical condition and the prohibitive costing. Everything is almost ready to come into the way of getting a good recovery for us.
Very, very grim situation. Sorry, Chhaya, you wanted to say something? I was just going to close. You want to add a line? Yeah, just add a line. Yeah, go ahead.
Yeah. Municipal corporation is going to supply liposomal. They are very aggressively working on it. So it will be available very soon to us.
Okay, but that doesn't change the fact that this is no longer a freak phenomenon. For anyone who thought that black fungus was a freak phenomenon, I think we now know, especially from the eye surgeons and the number of surgeries that they're performing, from the deaths that we're documenting here on the ground, that this is another complication in India's COVID battle, and it is a wake-up call. It's a reality check. I think, as Dr. Mani said, we now need stewardship on the administering of steroids and antibiotics in particular, because these could be wreaking havoc with our systems. And thank you to our experts for this very, very educative, very important conversation. Amit, Ambrish, Akshay, Chhaya, RK, thank you so much. And to our audience, we continue to be on the ground, bringing you the stories from the hinterland, from the small towns, from the villages, but always stay with the science. The science is changing, by the way. The science is not perfect. We're all learning every day, and black fungus is teaching us new lessons. We'll be back tomorrow at the same time. Thank you for watching. Goodbye. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.